All right, we're on. So this morning's discussion is on the heart attack. So where would the group like to start?
I think the most obvious one, at least for me, was this kind of like Munchausen syndrome, specifically with Costanza. Um, Initially, it felt kind of strange that he's eating a cucumber, and then all of a sudden he's like, "I'm having a heart attack." He's like arguing with the waitress about the bill, but still like having this heart attack. And then continues to kind of repeat this issue he had when he was a kid about like not getting ice cream. And so I felt very much, especially I guess based on the other episodes, like he very much wants to be coddled and cared for.
And is not.
And is not, right, exactly.
Yeah.
So
I mean, we've met Frank and Estelle Costanza. They're not a nurturing couple. So let's table that for a second, because whatever it is we decide we believe is going on with George in this particular episode, the next step will be why. Because when we put together a biopsychosocial treatment plan, I think we better understand some of that why. But first, let's talk about what might be going on. Now, we're going to have to edit this episode. We can't have him have tonsillitis, right? Because, and maybe we introduce this later as another way that we as a group have to rethink things. But let's say for the initial part of our discussion, there is no diagnosis of tonsillitis. There isn't, right? George comes to us with a chief complaint of chest pain, for which no underlying cause can be found, okay? At this point in our thought process, what clinical term might we use to describe George's behavior? So this is not a DSM diagnosis, but a descriptive term. Let's adopt the term psychogenic, all right? Whatever illness is going on, whether it's acute MI, whether it's an acute coronary syndrome, whether it's tonsillitis, whether it's other, we know that that condition is going to be psychosomatic, because every condition ever described is psychosomatic. Every condition since Aristotle that's been in the literature or not has both psychological and somatic components. So we're going to adopt that general idea as our definition of a psychosomatic illness. It's the same way, or it's the same thing as saying that whatever condition George or anybody else has for that matter has biopsychosocial factors contributing to its onset and progression. God bless you. It's true. Anybody have any concerns or further discussion about how we're going to arbitrarily define a psychosomatic illness? When somebody uses the term in a more demeaning way, please feel free to stop them and have this discussion, right? So somebody's diabetes, somebody's high blood pressure, cancer, depression, you name it, must be psychosomatic unless you're willing to dismiss there are biopsychosocial variables that aren't part of the equation, which you should never do. Brief pause. Considering, you're right? All right, so make sure everybody's on the same page. Now, at some point, a person may be told upon full investigation, physical exam, laboratory findings, CT scan, etc. Right now, we can't figure out the somatic component of your psychosomatic illness. At that point in time, what's the only thing a clinician could do or should do with regard to further investigation or general care of their patient? Yeah, better. Yeah, it's that simple, right? And maybe a day from now, maybe a month from now, the somatic component of that psychosomatic illness actually does manifest. But until then, please focus your clinical attention on the psychological variables or factors that might be in play in the individual's onset or progression. When that happens, clinically, we adopt the term psychogenic. Psychogenic is nothing more than saying that the individual's psychosomatic illness is at a point in the decision-making process where psychological factors are deemed to be central in the onset and progression. And reading between the lines, that means that we can't figure out the role of any somatic component. Questions at this point? Quick quiz question, which is not going to come up on your shelf exam, unfortunately. Who makes the diagnosis of a psychogenic illness? Given what we just discussed, well, anybody other than a psychiatrist, right? Right. If we're going to actually adopt the term psychogenic as being that psychosomatic illness for which the underlying organic or somatic component is unknown, the psychiatrist has no role in it, and they shouldn't. Does that make sense?
Mhm.
We're good? All right, very, very good. All right. At this point, though, the psychiatrist is going to get the referral. The person is going to walk in your office. I think even though it's a little bit beyond the scope of our discussion right now, certainly we can discuss this throughout the day. There must be unconditional positive regard. We're not going to promote the stigma that it's all in your head. But as we adopt that process of being empathetic, we do have that decision tree that we have to further now navigate. At this step in the process, what is the first thing that comes to our mind, and what should our clinical focus be on after patient safety, of course? That patient, we'll name him George, is in your office.
Knowing that they're not a medical.
Well, that's, I mean, his internist and the specialist, the unit cardiologist, has said there's nothing somatic going on here that could explain your current symptoms, Mr. Costanza. And I want to refer you to a colleague of mine, and have you meet with them until we do further testing and figure this out for you. So let's get you a follow-up in 30 days, but in the interim, we were able to have an appointment with one of Dr. Tobia's esteemed colleagues who was a third-year medical student, and now they're sitting in your office. Not that you would actually ask George this, but what's the first thing in your mind that you think you need to investigate, in as much as we're getting to that decision tree, bringing you down that algorithm?
Well, like HPI type stuff, I don't know when it starts, what the symptoms.
All that
are.
stuff, right? You did it, right?
Something happened recently.
Oh, that's going to be part of the routine psych eval too. That's already done. First question in your mind should be, is Mr. Costanza making a conscious effort to deceive me?
Mm.
Right, because if the answer are, and again, I always say this wrong, so I always have to go back and rephrase. Is there any observable evidence that Mr. Costanza is attempting to deceive me or provide misinformation? Because in the absence of such evidence, he and they never are, right? We always give our patient the benefit of the doubt until evidence exists that we have to change off that initial step one. In the event that no such discoverable evidence exists, our patient is telling us the truth. They're not trying to deceive us. We have a two-part differential diagnosis. What are the two diagnoses that will appear on your shelf exam? Conversion disorder, good.
It's somatic symptoms.
And somatic symptoms. And depending on whether it's A versus B, has everything to do with what the presenting symptom is. In this case, it's chest pain. We're going to call this somatic symptom disorder, and we're going to ask Mr. Costanza to come back in 30 days, right? That's the psychiatric evaluation. Between our initial eval and our 30-day follow-up, evidence actually is turned up that shows that Mr. Costanza, that George was making a conscious effort to deceive us. When we bring him back in about a month later, we're going to discuss an additional two-part differential diagnosis now.
What kind of evidence do those people come up with if they're trying to deceive? Like, how?
Well, he shows up to your next appointment with workman's comp papers, okay? He tells you that he wants to sign a consent so that his medical record can be submitted as evidence because he's suing his employer. Right? Now, that doesn't mean it's a slam dunk. It just means that in the absence of such evidence, we have to stick in column one, somatic symptom disorder versus conversion. Now that evidence exists, we do expand and broaden that differential. Now, whether it's true or not, further investigation. Right? But we are allowed to talk about two additional illnesses, which include
Migraine. Much healthy.
otherwise known as factitious. I'm just afraid that if you look for Munchausen's on your shelf, you're not going to see
Okay.
factitious disorder, right? That's a two-part definition. C versus D has everything to do with the motivation behind his disease, right? If it's external, right, good, right? So external, like those workman's comp papers, malingering; internal, otherwise unconscious, would be, factitious, right? So there's your 2 and 2, all right? There are related illnesses too, and I think the related illnesses come in 2 varieties. Straightforward comorbidities, like post-traumatic stress disorder. You're getting a little ahead of ourselves, right? But you knew where I was headed, right? And then there are those that are not necessarily in the differential, but additional diagnoses to consider. All right. So let me put it this way. I would look at something like PTSD as a comorbidity. This next set really is furthering the differential that might actually replace malingering or factitious or conversion or somatic symptom. And that's something called illness anxiety disorder. Right. So again, additional illnesses come in 2 varieties. This is an arbitrarily categorized discussion now, right? So don't take this as gospel. One will say are comorbidities. Post-traumatic stress disorder is the example. The other one are differentials, meaning that yes, they could coexist, but they could also replace something that we're basically having as a provisional, like in this case, somatic symptom disorder. And that's illness anxiety disorder. Illness anxiety disorder, formerly known as hypochondriasis, focuses less on the actual somatic complaint and the anxiety and distress that's caused by it. So this is related to the obsessive compulsive related disorders, and it's the preoccupation with having a serious illness that becomes the focus of clinical attention, right? Not the somatic manifestation of an underlying illness. That make sense?
Mhm.
With all the above now, what do we think is going on with George Costanza?
You said, but,
You think it's factitious?
Given, I don't think he had like workman's comp or like a outside external motivation to do it, but he definitely is the kind of person that like wants all eyes on him, wants the attention, like you were saying, he didn't get from his parents. And you can see like in the way that Jerry and Elaine kind of like, oh, like, you know, if you happen to die, like, what about that thing that I really like that you have? I can have that. And not really like acting very concerned about him.
And I'm perfectly okay with that differential as it exists within this single episode. I think it's just a season one episode. However, like even in real cases, in real patient centered cases, we're going to have continued observation and continue to follow up. And if at any point you believe the focus of clinical attention should shift to George's preoccupation and not the somatic symptom per se, illness anxiety disorder will leapfrog in our differential. These again are related illnesses, even though they're in different chapters. Well, I shouldn't say that. The somatic symptom and related disorder chapter currently does include illness anxiety disorder, aka hypochondriasis. It will be moved out into the obsessive compulsive and related disorder chapter in the next revision, very likely.
And thinking of like him possibly having illness anxiety disorder, they tend to differentiate from somatic symptom in that oftentimes the anxiety is surrounding the potential of having an illness, but not necessarily always having a somatic
Exactly
symptom.
right.
There's a somatic symptom, they have something, and G was like chest pain with the left arm involved. So how do you, I mean, I guess you can have a somatic symptom with illness anxiety, but, and then my second question with that is, with illness anxiety, do they often have anxiety about, like, do they ruminate about a specific symptom for a very long time or specific illness, or do they circle around like many different ones based on like one little symptom?
It varies. There's really no given there. But your initial observation is spot on. When the anxiety becomes the focus of clinical attention, you're likely dealing with illness anxiety disorder, right? It's a preoccupation syndrome, just like body dysmorphic disorder. the individual is preoccupied with having or acquiring a serious illness. It isn't necessarily the illness or presentation itself, and that helps differentiate. The other part of this too, and again, this is not always a given because human behavior defies simple logic. But very frequently, at least on shelf exams, the individual's affect will not be anxious and otherwise be inappropriately calm. And sometimes, especially within conversion disorder, we call that labellin deference. So that very a matter of fact affect is the direct opposite of illness anxiety disorder. Yeah, so that's something to pay attention to as well.
Really happy to find out he doesn't have a heart attack, but that's kind of overwhelming, I think, like, if you found out you didn't have that condition, would you necessarily see the person who goes before?
That goes against, I think, both illnesses. Yeah, that's difficult to process, but further complicates this case. Yeah, for factitious, when the individual is making a conscious effort to deceive you, maybe they're acting. Illness anxiety usually doesn't respond like that because it's the very preoccupation with, despite evidence to the contrary. We can reassure you, Mr. Costanza, this is not a heart attack. We can assure you this is not tonsillitis. We can assure you it's not C, D, or A, doesn't matter. The preoccupation persists. So that does weigh against. I think it's more suggestive and supportive of your initial diagnosis. It doesn't make sense, but then you might be active. Any other observations? Focused on George.
Yeah, I think for me also, I guess, supporting the idea that he didn't actually think he had something wrong with him was, I guess, when the doctor comes in. So it's like, oh, but we'll still like hold you for observation. Just like the calculations in his head about like how much is this gonna cost? How's this like other holistic doctor gonna cost? Realize it's $38, and it's like, okay, I can divert and get all the attention I need in a different spot for like significantly cheaper. And then he does that, and then actually it's like,
We see this
No
as part of a
problem.
recurring behavior in
Right.
George. He's very frugal, miserly spending style. He definitely has that single criterion from the obsessive compulsive personality. Although I don't think has another diagnostic criteria suggestive of OCPD. But here we are again. Yeah, that's a very, I think, salient personality trait in this character. Other characters, the heart attack. We have about 5 minutes more.
I just have a question because I don't know what this could be, but it was weird. The doctors, like, what's wrong with him?
Which one? The doctor at bedside or the holistic healer?
Oh, the like doctor at the bedside. It's like Elaine's tongue. Yeah, I was like, that's a problem, but I don't know where it fits in. Yeah.
Well, it's definitely unethical. We could talk about bioethics there. I have a hunch what path to go down and what I might discover in psychotherapy. He seems very, what's the word I'm looking for? Very focused on, and I don't know if I'd say preoccupied, but it's borderline preoccupied with his particular subspecialty in the organ. And I wonder where that comes from. Now, we're all passionate about what we do, but I still can't believe you guys have not changed your mind in psychiatry. But he does cross a boundary there. And again, it might be a boundary related issue and only a boundary related issue, or it might be even more complicated than that. And I'm just wondering what his parents thought about the particular field he went into. Right? And whether or not he's, maybe parents of two subspecialties that are not ENT. So, actually, he's a cardiologist, right? No, he's ENT.
Internal.
I just have.
The tonsil roll.
Yeah. Well, I really want to get on his relationship which is with some irony, because of course that's our focus on George, and it's continued to be our focus on George, and there might be a similar focus here in a parallel character, same episode. In the few minutes we have left, any thoughts on Tor? The other doctor?
Eccentric, very common rage against the machine and the society, and clearly I felt like he had
it's a connection with him between him and Kramer.
Mhm.
They're kind of like sort of the same person, but in different kind of fields
Uh-huh.
of what they do.
Mhm.
Um,
Did he make you uncomfortable at all?
yes.
Did he make Jerry uncomfortable at all?
Yeah.
How do you tell? How do you know?
The voice in his head. was saying
He was
something.
smiling,
And also
like
like his face, yeah.
yeah.
Yeah, and then we see a nice example of this particular character, the character Jerry Seinfeld's use of humor as a defense mechanism. That was a very uncomfortable scene for those involved, including in as much as we identified with the character. And that character probably would be Jerry. Kramer, not so much, right? I mean, it seems like Kramer and Tor feed off one another. Tor did give you a potential correct answer on your shelf exam, because he talked about how near the Arctic Circle, individuals who live up there have very culturally bound behaviors, including sticking their head in the snow.
Mm.
Um, any idea what the single best answer of that culturally bound syndrome is?
Right.
You forget, but if you saw it as part of a multiple choice, you probably would recognize,
Yeah.
which is the important thing. Right? Piblokto or Arctic hysteria?
Mm.
It comes up on shelf exams.
What is that?
Piblokto or Arctic hysteria. Usually you'll get one word and then the other in parentheses. It does come up, and
And they're being evaluated for their like decisions and like here as compared to their decisions there, or like what
right,
kind of question
Right.
are we seeking there?
that's my next question is, if someone with Piblokto actually came to clinical attention because maybe there were signs of frostbite in terms of what happened or some other reason, and you heard of this quote unquote tradition. I think one of the things the clinician must do is differentiate between a culturally sanctioned belief or behavior and a culturally bound syndrome. What differentiates the two? I'm going to give you what binds the two, what's similar, and that is both are thought to be geographically isolated, right? That's the similarity, but that's not the board question. The board question is really going to focus on what differentiates those behaviors.
Culturally bound and culturally
Sanctioned.
Well, sanctions like permitted, within the court, so one's permitted and one is not
So
necessarily accepted.
right.
Is culturally bound, I don't even say it, like it only really occurs within that culture due to certain beliefs that they hold or something. So it's like that.
That's the same. That holds the same for culturally sanctioned too, though.
But what's it called with the whole like is it urine or semen, something to do with
Guru?
illness? Yes, that is still like within the culture. Is it like a very fair sanctioned explanation, or is it like
No, it's
oh they're
culturally,
ill?
it's culturally bound.
So that's kind of how I'm differentiating.
Right. When we hear the phrase culturally bound syndrome, I would like you to focus on the word syndrome.
Mm.
Right? Because even though it's geographically isolated, Kuru, Indonesia, Piblokto, Arctic Circle,
Mm.
within that region is considered to be abnormal or syndromal.
Mhm.
Right? A culturally sanctioned belief, culturally sanctioned behavior, I want your focus to be on the word sanctioned. So in that geographically isolated area, that behavior is normal.
Mm.
On your test, one is going to be provided psychiatric care. The other one is going to be choice D, reassure, discharge with no further follow-up.
Mm.
Right? Culturally sanctioned beliefs or behaviors may break the law, but as a doctor are normal.
Mm.
Culturally bound syndromes are syndromal, they're abnormal, even in the context of one's culture. So when that culture, that person from that culture travels and now is in your office in central New Jersey, there's a diagnosis to be made and there's a treatment plan to be put in place. One that is going to be culturally sensitive, but a treatment plan nonetheless.
Mm.
That brings us right up to 25 minutes after the hour. We're going to stop here. For those following at home, we're going to log right back on to our other link for our 8:30 didactic. Thanks.